Dear colleagues, my name is Maythem Alfartousi. First of all, thank you for joining my presentation. Today I'll talk to you about critical points in endodontics. I assembled these points non-sequentially, so I'll start from the bottom, cost, valuability, time, and then I'll jump over to the anatomy, pathology, classification, choice of treatment based on evidence. I'll talk less about devices and materials, and maybe profoundly about outcome and some studies that were conducted for this purpose, to study the outcome. First of all, when I was preparing myself for this presentation, I searched the web for the definition of value. What is the meaning of value? I found many definitions. One of them was commercial definition. The definition is estimate the monetary worth of something. In order to give a value of something, you say this is the commercial definition, this one is cheap, this one is expensive. You are giving it a commercial value. And this is true because either you have something that is valuable, must be expensive, or you have another thing less valuable, or maybe not valuable at all, very cheap. And if we take this instant or this example in our endo treatment, the treatment will be valuable for the patient if they pay for it. For me, my treatment is always valuable because I can't say I do perfect endo, but I can say I try my best in order to perform a perfect endo. That's why the treatment for me is valuable. If I don't charge for the treatment, the patient won't understand my effort in order to get to this level to perform endo if he doesn't know me. So even if he knows me, if he didn't pay for the treatment won't be valuable for him. I can give you another example. Gucci, we have fake Gucci and real Gucci. The real Gucci bag may cost somewhere between $1,500 and $2,000. The fake Gucci, like the one here represented in the lower right corner of the presentation of the screen, may cost somewhere between $5 to $15. If you look carefully, you will see maybe only two women standing there. One of them is the sailor. The other Gucci stores, you see people waiting there, men and women. Maybe men want to buy gifts for their wives or girlfriends. And if you look at the upper right part of the screen, you see security guys standing there, preventing people from coming inside the store. They are waiting people there. Some of them is seeking and try to look inside the store. I think the store is very big. They may get all of them inside the store, but they don't do this on purpose. They want the people to wait instead of thinking on patient. They want the people to wait outside because this is kind of marketing. If you wait and then get inside the Gucci, you won't go out without buying anything. This is Gucci. I waited outside and now I had the chance to go inside. I will buy it. If they pay more, if they purchase more for the Gucci, they will be happier with the Gucci and they will take care of their bag. But if you buy this fake Gucci, you are not going to treat it like as if you have the real Gucci. And this is, we can take this example even for the endo treatment. For example, 2 years ago, I went with a friend of mine to the northern part of Germany. My friend was seeking and looking for dental offices. He wanted to take over dental offices to start working by his own. We went to many dental offices. One of them was very old dental office. The units, the devices, everything was old. Even the colleague who wanted to sell his office was 76 years old. He was very communicative. He talked a lot. We couldn't interrupt him at all, really. We were very happy when we left the office, but he said something very important. He said to us, the mistake that I made in my career is that I didn't charge the patient for the treatment. I made it here in Germany. We have this public insurance, public health insurance. I made it on cost of the public health insurance, which is very less money. That's why many of them, too many, didn't take my treatment as a valuable treatment in consideration. They didn't like. I had many issues with many patients because they didn't respect what I perform. I can imagine really that he didn't. I don't think he performed dentistry the way other dentists perform their dentistry. Because if you charge for your money and you think and you sit with yourself, you charge too much money, you have to perform the best, because patient will understand and will see the difference between your work and the work of other dentists who are really competent. So you have to work on yourself and charge the patient for the treatment. I know some people work in villages or in areas where they can't charge the patient, depend on their situation, but generally you have to make your treatment for the patient valuable and for yourself. If not, we are fighting with other problems in this occupation. We have the problem with the anxiety and depression. Sometimes we perform a very good treatment, not only endo treatments, other treatments, but due to the side effects, due to the complication that may occur through or after the treatment, we may take we may suffer from depression. For example, if we have patient and we start treating him and then we break an instrument inside, you will get this feeling, blood coming up to your cheeks, and this is very bad feeling. Then you start thinking, okay, now how can I tell the patient that we have this problem? Even if I told the patient about this before, the patient will be not happy about this news. So that's why we live with anxiety and depression. There is very important study. There's very important study from ASIF that published this study in the year 2022. This is months ago. She did send questionnaire to a huge amount of dentists in the Kingdom of Saudi Arabia, and as a result, over 65%, I think I may one of them if I live there, committed that they have anxiety, some degrees of anxiety, or sometimes depression. They suffer from anxiety and depression in this occupation. This may be because the demand of the patient, the demand of any individual may differ from the achievement. I want something, but I can't accomplish this thing. I want to do the best treatment, but sometimes I have side effects. Sometimes I have for example, overfilling. And then I'm not able to remove the or retrieve the canal. Sometimes we have short obturation. Okay, with short obturation, we can deal with it. But if we treat the patient for over 2 to 3 hours, maybe sometimes more, sometimes less, the patient is not able to open his mouth again. So we have to send him back and tell him, look, we have to retrieve this canal because we have this short obturation. This will cost us nerves, and it will cost us negotiation with the patient in order to have him back again. We deal with MB2. MB2 is a story at itself. Sometimes you don't find MB2. What about having CVCT? CVCT is very expensive. We have this depression. We have to deal with depression. Our occupation is not easy for our mental health. So if we have this problem, how can we overcome these problems in life and our occupation? How can we overcome it? First of all, we have to improve our skills. Improve our skills in order to make our treatment valuable for us. If we improve our skills on the other side, we are going to have less complication maybe. And we have to make the treatment valuable for the patient. If we make the treatment valuable for the patient, we can charge more. And with these 2 points, what I want to say, with these 2 points, we could overcome the anxiety story and the depression story. So my appeal on you, make your treatment valuable for the patient, valuable for you. Charge the amount that you find reasonable and fair. If you don't do this, I think you are going to lose. One day, maybe you are going to change your mind and start charging for your treatment, or maybe you will regret it without doing anything. So now jumping to the anatomy. The anatomy, we have many classifications. One of them is the Alfartousi classification. I think every one of us have heard about Alfartousi classification. We have many posts on Facebook where we read, okay, I am doing this endo, I did it very well, I have this Alfartousi classification. I bet every one of them goes back to the internet, to Google, maybe to some books, in order to find what kind of Alfartousi classification do I really here have. Look at these canals. I think I usually, if I want to mention the Alfartousi, and I do this when I publish case reports, or maybe when I publish on Facebook. Sometimes I do this, I have Alfartousi, but I always have to go back, and I bet everyone's doing this. So this is not easy, and this is not helpful. Always to go back and search for the classification. So look at this one. This one is more difficult. Now we have, look at these numbers. We have XX and then 3 times. You have to think, you have to go back to with your memory. Okay, the Latin numerics. Okay, we have this is X is 10, and then at the other side maybe 18. You have classification number. You are not going to really to keep it in your mind. You always have to go back, and this is not the real classification. We know that the anatomy of the canals is usually more complex. The same is with the Vine classification. This is, we have from type 1 to type 5. I think I can't keep this in my mind. I always have to go back to the books or to Google to find to classify my canal, to give a classification to my canal, and I think this is senseless. This is not senseless. This is, or not less useful. It is only useful if you are going to publish something, if you are publishing case report, or you are talking on paper about it. What I find very useful and very right and easy to understand is this classification, the Ahmed's classification. Ahmed classification is very easy to understand. You don't have to go back to the books. Everyone can classify every teeth using the Ahmed's classification. We start with the small numbers and the number of the roots and then the number of the teeth. For example, one root for the tooth 44, we have one canal divided in two, and then we have 3 orifices. So 3 foraminas. Look at the upper molar. We have tooth number 26. We start with the number of the root, 3 roots, tooth number 26. MB has 2, the mesiobuccal root has 2 canals. They meet in the middle, and then we have three foraminas. The distal buccal has 1, the palatal has 1. It's very easy. The critical opinion of mine is it's easy to write down. It's difficult to type, maybe. It is difficult to say it orally to someone who is not seeing these numbers. So we can say 326 MB2 13 and then DB1 P1. It's a little bit difficult, but it is very easy. My appeal on you: use this classification if you want, if you can write it down, or if you can type it. So now we talked a little bit about anatomy. We'll jump to the pathology. I'll start with the classification. Sorry for writing classification here wrong. The K is in the German way of saying classification. This is the German classification. So we have resorption. If we talk about resorption, there's many classification based on localization, etiology, pathology, physiology, and many other classification like the external. If we talk about the external resorbable or the cervical resorbable, the invasive cervical. This is the Hydra classification. We talk about the invasive, what we call again, invasive cervical invasive resorption. There's this Hydra classification. Hydra classification. This is now a pattern of how the classification is. We have class 1 when we have small fallen area with resorption. Then we have class 2, class 3, and class 4. In my opinion, sometimes you can't clarify. You can see the difference between class 2 and class 3 on the 2D radiograph, because depending on the arrows of the X-rays, you may see for example, in class number 3, you can see only the big fallen area, big resorbed area, and the small one, you may not see it. You need to have CBCT, and not every one of us has CBCT. So if you don't have CBCT and you clarify class 3 as class 2, and then try to raise a flap, and then if you, in addition to that, have a bad restoration, you may recognize after raising the flap that this one is compromised, so you have to take it out. You have to extract the tooth. But for the patient, this is not good, because now he has 2 problems. The first one, you talk to him about raising a flap and removing the resorption and treating the tooth, and then you raise the flap and the tooth must be extracted. He is not going to be happy. Even class 4, this 2D radiograph is not enough. You must have 3D. And in some cases, you can treat the tooth, in other cases not. So that's why this kind of classification is not very useful. What I find useful is if we start to make it very simple, two classifications, two kinds of resorption, internal, external resorption. Starting with the internal one, we have surface resorption, when the resorption affect only the surface of the wall of the canals. It's not going deeply. We don't have this boil. This is not easy to diagnose. I think in this case we must have CBCT. Always in resorption, CBCT is very useful. Then we have the inflammatory, which is very common, inflammatory internal resorption. We have then the replacement resorption, which is less common than inflammatory, but more common than the surface one. Replacement means resorption and the bone replace the resorbed area. Same thing with external, we have surface. It is not easy to diagnose like the surface one, like the internal one. And then we have the inflammatory, which is very common. We have the replacement, which is always common. Replacement, as I said before, removing part of tooth, conducting bone. And then we have the invasive cervical resorption. This is where I saw when I started to, not really speaking the name correctly, invasive cervical, which is very common. So this is very simple. I don't think we have to talk much about etiology. So we have sometimes these patients, when we start to ask them if they have had trauma, auto treatment, said no, bleaching, no. Then we start thinking what else could be the reason why. And then someone talked one day about the cat. Do you have a cat? So, and if I say yes, he will believe on you. Whatever you say, this is a very good doctor. He knows that I have a cat. Even there's no evidence that having cats may lead to cervical resorption. This is another subject. We are not talking about it. We are talking about critical points in endodontics. And the next one is the periapical scoring index. Periapical scoring index. I inserted this slide on purpose. This is very old. You can't understand everything of it because whenever you have paper talking about the periapical scoring index, they put this picture inside. This is this is not very easy to understand. That's why I conducted it here. As I said before, we have periapical index number 1, 2, 3 to up to 5. Between 2 and 3, sometimes not easy to see the difference between them. Between 3 and 5, you may understand the difference. It is better to jump to the next slide where we can understand the periapical index based on CBCT, which is understandable. It's better than the other one. This pattern is very clear. We have 0 where we have nothing. Then we have 1. The lesion is about 0.5 to 1 millimeter, and so on, till we have the E, where it is bigger than 8 millimeter, and the cortical bone is boiled. We have if you touch it with your hand, you may feel this thickness, abnormal thickness of the cortical bone, of the apical bone at the apical portion of the tooth. And if it perforated, this is then the number D. The same we have here in the lower jaw. Some people like this classification, others don't like this classification, because they say if we have, for instance, if we have the class 5 or if we have the class 3, and if both teeth are symptomal, this one doesn't affect the choice of treatment. We have to perform endo at class 5 or at class 3. That's right, but we will see later when we talk about outcome, sometimes the prognosis of the treatment or measurement of the success may be affected with or depends on the size of the apical lesion pre-operatively. If the size is big, the prognosis will be not that favorable like when the size is smaller. So now we talked about pathology classification, not every pathology classification, but these points that I want to talk to you about. This is a kind of statement, my own statement and my own opinion about some points that I consider important in endodontic treatment. We jump to the next point, which is the choice of treatment based on evidence. We know that evidence-based dentistry or evidence-based medicine is integration of 3 things: patient-related interest, patient values, what do the patient want, the best scientific evidence. We all know this pyramid. This one represents stages of evidence. At the bottom we have the worst evidence, and if we are going ascendantly, we will find more stronger evidence studies. At the bottom, at the top of the pyramid, there must be the guidelines. This one is a little bit old. I took it from other slide for me. Guidelines. So then we have the clinical expertise, my own expertise, your own expertise, but alone it is not important. We must integrate the other 2 points. I can give you example of doing best scientific or choosing treatment up on the best scientific evidence and clinical expertise, but not taking the first point, the patient values, in consideration. This is a case of mine. The first one at the left is where I start to do endo. Directly post-operatively, this patient came to me. He said, I have pain, please extract the tooth and insert an implant because my insurance will pay for implant, will not pay for crown or maybe root canal treatment. So I convinced him to do the root canal treatment, told him your own tooth, don't do this to yourself, it's better if you will try, it will cost so much. So he said, okay, you convinced me, let's do it. We did the endo, and when I was finished with the endo treatment, I told him, now we have to insert the crown, we have to overcover the tooth with crown. He said, well, you didn't tell me that before. I don't have money. I'm seeking now for a new job. Maybe later, if I have a new job and I have more money, I can spare, I'll come to you and we have this. But I'm not happy with this information. This is what he told me. He came after 6 months for the recall, said everything's okay. Why do I have to insert a crown on it? Talk to him again about the importance of having crown. Otherwise, the tooth is going to fracture, to break. He came after 18 months. We did this picture, this radiograph. Here we can see the healing of the apical region, but the tooth was fractured. We had to take it out. Nobody of us was happy. I consider this as failure because it was not evident enough. I didn't take his value into consideration. If we jump to the next, we are finished with the choice of treatment based on evidence, devices and materials. I can talk briefly about devices and materials. As we know, everything is expensive. The devices are expensive. We have many devices, especially for normal endo treatment. If you want to perform proper endo, you must have these devices like microscope, for example. If you do endo under microscope, you see more. If you see more, you treat more. And don't forget the way how we sit under microscope, the ergonomic benefits of microscope and so on. So you have these devices, or many other devices. They are very expensive devices. This is CBCT, I think. So if we want to perform a good endo, we must have this device. If we want to do a professional endo, we must buy these devices, which is more expensive. Now everything is getting complicated. Don't forget to have these burrs and maybe this one from the shower to pick up some broken instruments. The mirror must rhodium coated, otherwise under microscope you will have this double picture, double reflection. If they are rhodium coated, we won't have this bad effect. This device is also important if we want to perform apical surgery. This is too for apical surgery. And if we really not very happy and want to get rid of all of it, we can still perform still perform dentistry with this one and only device. So this is the main instrument that are used in the history of dentistry, more than any other instrument. So we talked about devices, materials, another story. I'm not going to talk about materials, but now the outcome. Outcome is very important. Every endodontist must read two very important studies. One of them is historical, is the Toronto study. When it comes to outcome, when it comes to the result of the treatment. Toronto study is very important. The aim of this study was to study the outcome after 4 to 6 years after endo treatment. They did the endo treatment at Toronto University, and they wanted to recall the patient after 4 years. 4 years. They did endo on 350 patients, totally 405 teeth from 350 patients. That means some patient had 2 or 3 endo treatments. They did it from this person at the university. After 4 years, they recalled the patient. 109 patients with 128 teeth were discontinuous. They didn't come again. 9 of them died, deceased. 100 relocated. They moved to another part of or maybe outside of Canada. 136 teeth were taken out of the study because the patient declined to come, or they didn't respond. They sent them letters, they didn't respond. Some other patient came, 21 teeth of them were extracted. The result was 120 teeth from 405, somewhere between 25 to 30%. But the result was 92% of the treated teeth that did not have apical lesion healed after 4 years, and 74 of the apical periodontitis teeth healed after 4 years. So they call it phase number 1, and they wanted to do it better with working on recall management, and that's why they started the second the second study. This study started, I think, in year 1993 or 1991 in Toronto. After 4 years, they started the new study. Phase number 2. The total amount of the patient was about 371, with 442, some more teeth. They treated them after 4 years. 4 patients died. 105 were moved. 11 patients declined to come. 121 did not respond. They sent them some, they didn't come. The rest, total amount of 122 teeth from 130 patients. Some of the patients came without having the tooth inside because these teeth were extracted, removed. So the second attempt, same result, same amount of recalled teeth, and the result is very similar to the first one. 94% healed, 81 from the periopical lesion preoperatively healed. The third attempt, they worked more on their recall system. They encouraged the patient to come. They offered them having annual tooth cleaning without paying for it. The same result, 132 teeth were recalled, examined, and we may see a smaller number than the other studies, but there was no significant no big significant difference. The difference was not that significant. So 89% of the treated teeth healed, which have not have periopical lesion, and 73% with periopical lesion were healed after 4 years. So they decided to start the last phase. They encouraged the patient with money. They paid for the cost of the transport cost. They paid for, if they are from, they paid for the flight. If they relocated, they paid for the. If they relocated, they paid for hotels. They offered other treatment without paying it, and this is important. In Canada, everything is very expensive. And they came to the next result from 582 teeth of 511 patients, 137 respond. And the total result was similar to the other 88%. This study has weakened point. They pooled the results of every study, and they came to the point where they said, okay, we know the teeth from the patient who didn't respond and come, and we know similar teeth that we treated before. When we see the result of these teeth after 4 years, we can compare them, we can add them. They played with the statistic, and this statistic is always a game for people who publish. With statistic, you can make your result better or worse as you like. They play with numbers. They always have solution for that. But this study is very important. It is not perfect because they don't take many points of views in consideration, like the history of the medical history of the patient, the disease history, and the disease situation of the patient. If he is immune compromised or not. For example, we have the study from Al-Ghufaili. She studied the bone healing, apical bone healing for patients who suffer from high cholesterol degrees in their blood and take statins. And she came to the result that patients who take statins may have better or beneficial results for the healing of the apical region comparing with other patients who suffer from the same illness but they don't take statin. So there are other studies talking about these things, other studies mentioning that some factor may affect the healing, like if you have patient if you have patient with HIV, or if you have patient who takes bisphosphonate, they are immune compromised, the healing won't. If you have younger patient comparing with older patient, younger patient will have quicker and better healing than other patient. So these points were not very important for the Toronto group, but we have then NG, Dr. NG, a strong woman. Dr. NG in London at the university, she started another study which is very important for people who do endo. This study talks about the factors that affect the healing of teeth that were treated at the university from students but under supervision of professors and endo doctors. So they recalled them twice annually, the patient, and they register the situation, the healing situation of the periapical area, not after 4 years, after 2 years to have better response. They could collect 702 teeth as a primotherapy and 750 for retreatments. 11 factors, one of them abstaining of CHX. Nowadays, CHX not that important. We need only sodium hypochlorite and mostly EDTA. If we have CHX getting in contact with sodium hypochlorite, we may have leakage of adhesion of the filling with the canal and problems with the coronal restoration. This is another issue I'm not going to talk about. This is one of these factors. The next factor is periapical lesion. Do we have periapical lesion or we don't have periapical lesion? As we saw from this Toronto study, they call it the Toronto study. If we have periapical lesion, the percentage of the prognosis will be less than if we don't have periapical lesion. The size of the lesion is very important. Bigger one, less prognosis, smaller one, better prognosis. Sinus tract presents not good prognosis, absence better. Patency, which is very important. Patency means they want to tell us that if you can instrument all the canals, even the apical portion of the canal, you may treat it better, you may shape the canal better, you may reach every area with your irrigation, agitation, and this is here mentioning the cleaning. And the use of EDTA is important because with EDTA you may remove the smear layer. If you don't use it, you may have smear layer somewhere. This is problem. Perforation make the prognosis less favorable. If you don't have perforation, you will have better result, flare up, because flare up comes when you play with your instruments in the apical area, or when you push bacteria to the apical area. You may have a foreign body reaction, or mostly with bacteria, up to 90% you have bacteria there. You pushed it outside with flare up. You have bacteria, you have infection, you have periapical lesion, even if you can't see it sometimes, if you don't have preapical lesion before the treatment, and this leads to bad prognosis. Not bad prognosis, less better prognosis than not having flare up. Overfilling, same issue. Overfilling means foreign body reaction or bacteria. And then the last point is the corona restoration. You must have good, must seal it coronally. Otherwise, if you have leakage somewhere, you have bacteria inside it. So that was the part 1 of the NG study. The part 2 of this NG, Dr. NG, was talking about survival. After 4 years, if you begin your treatment with big apical lesion, and this is the volume of this apical lesion is getting smaller, but after 4 years still there, it's getting smaller, but it didn't disappear completely. Usually due to the ESE, you have to consider your treatment as failure in treatment, no success, failure. So, but if you have this issue and it's getting smaller, and the patient doesn't have symptoms and he doesn't want to have apical surgery, and you have the feeling, okay, if I monitor this case and wait more, recall the patient, I may see after 1 to 2 years maybe completely disappearance. Now we take about survival. The tooth is functional there, is still there. We have no symptoms. It's getting small, but very, very slow. We are talking about survival, not success. And there's 11 factors due to NG who affect the survival of the tooth. The first one, which is very important, I mentioned before, the history of medication, history of other therapies, and the health issue of the patient. The probing depth, which means do we have periodontitis or we don't have periodontitis. Sometimes you have periodontitis and pulpitis. Sometimes you have this endoperio lesion. If we have only endo lesion, the prognosis is better than having both of them. Pain, discharging sinus. Sometimes the tooth and the upper jaw is okay, but in the sinus we have infection, and this infection may be cognitive for the tooth, and they may take their way to the tooth, and then we have a tooth infection. The cause of this infection of the tooth comes from the sinus. So that's how I understand discharging sinus. Perforation, that with perforation, without perforation. It is bad if we have perforation for retreatment cases, because usually the microorganisms that lead to this, to the reinfection, are more resistant to medication or sodium hypochlorite or sealers than other microorganisms, like Enterococcus faecalis, for example. Iatronic perforation, patency, we mentioned this before. Cast restoration versus temporary restoration. If we have cast restoration, usually cast restoration are they seal the tooth if they were made properly. The temporary restoration, they may lead to leakage for bacteria to come inside, because they are not made, usually they are not made very properly, as if you are having this definitive restoration, like cast restoration. Extrusion of root filling, we talked about it before. This is logical. Presence of cast and post and core. This point they are talking here about the having post and core sometimes is important, mandatory, in order to prevent the tooth from fracture. So, because if the tooth fractured, the tooth didn't survive the root canal treatment. Not directly because of the root canal treatment, but because of lack of corona restoration or bad corona restoration. Proximal contact, not good proximal contact, lead to food impaction areas. We have food impaction somehow, and we have margins there for the restoration. We may have reinfection, caries, and then bacteria inside, and problem with the survival of the tooth. Like, not only having this, maybe these teeth may break. Terminal location of tooth, this point, we have then iatrogenic perforation. I wrote it here, not correctly. Iatrogenic perforation for the retreatment cases. Well, this is when I talked about the retreatment and the microorganisms that are difficult to treat because of their ability of the resistance ability. So now we talked about all important points. Outcome take-home points are: we have to raise the value of the treatment. We have to raise our value in our eyes and the value in the eyes of the patient. We have to charge more for our treatment. Always, I don't need more is not correct. We have to charge the fair amount that covers the treatment and covers my history till I get to this point that where I can say I have very high value. We have to involve the patient with the treatment decision. If the patient is not willing to pay for the treatment or to have this kind of treatment, why should I treat him? If we say, no, I don't want to have this tooth, extract it. I don't need to treat him. I respect his decision, but I must not treat him. You can say, go to other dentist, let the tooth extract it. Depends on where you live and what you can do, and law in your country, and it depends on it. You can make another decision, but you have to respect the decision of the patient. In order to remain mentally healthy, we have to learn not to take the work home with us. Otherwise, we will suffer more from this depression and anxiety in our life. And this may affect the years that we are going to live more in this world. We have to, in order to remain scientific in our work, we always have to analyze the studies, practice evidence-based dentistry, and keep tuned with the new paper and this acceleration of scientific development that we can see in the world. Prevention from mistakes. We don't need to accelerate our treatment. It's not right to make the treatment very fast. It's not right to it is important not to rush, but it's also important not to lose time. We don't have to make a very quick treatment, and don't have to lose time as well. if we make the treatment very fast, we may break an instrument, and then we'll spend much more time fixing this problem with much more nerves and costs, and for the patient, nerves too, and nobody is going to be happy after this result. And the last one, which is very important, every endodontic treatment is difficult treatment. We must not underestimate the endodontic treatment. Everyone is difficult. They may differ among themselves, this tooth, that tooth, but we don't have to underestimate endodontic treatment or any treatment. Thank you for listening to me. I hope you are still awakened. Make good endo. Thank you.